your introduction and your nice words. Hello, everybody. Thank you for inviting me to speak today. Since I qualified in Western medical doctor in China in 1990, there has been a huge growth in hospitals and Western medicine in my home country. But as hospitals, treatment and antibacterials have developed, so too has antibacterial resistance. Now, it is a major problem in China. I have seen patients die from drug-resistant bacteria infection, such as MRSA and MDR-AD. In China, same as England, we want better to understand the drug-resistant bacteria infection. So, I have done much research into the drug-resistant bacteria in Beijing Zhi-Xiang Hospital. That place I worked until last summer. Now, I'm talking about my investigation into the circulation rate and drug resistance of A.Baumannii in the blood specimens from ICU patients over a 2-year period. The method witness blood for culture was collected after strict skin disinfection. Everything was done in line with Chinese National Clinic test procedure. The Vitic 2 compact automatic bacteria identification and drug susceptibility analysis system was used. It was for bacteria identification and drug susceptibility evaluation. The circulation rate and drug resistance of A.Baumannii in the blood samples were statistically analyzed every 6 months and tested by T-square. This table about the circulation rate of A.Baumannii at each days. I found 360 strains of pathogenic bacteria in the ICU blood specimens during 2012 and 13. It includes 59 strains of A.Baumannii. The circulation rate is about 60%. This table about the antibacterial resistance rate of A.Baumannii at different stages. The drug susceptibility tests select the resistance rate of A.Baumannii to 12 after 15 antibiotics resistance rate of A.Baumannii of less than 50% were only for cephalosporin sulfactam at 5% and minocycline at 34%. The resistance rate of A.Baumannii to almost all commonly used antibacterial remained at a high level with no significant change during the 2 years of monitoring. A.Baumannii in blood specimens in ICU during 2020 and 2013 were all multi-drug resistant A.Baumannii and DRAB for short. Discussion: why MDRAB reproduce and spread at ICU? It's well known that A.Baumannii are common bacteria in the environment with strong vitality. They are often found at bronchial and venous catheter. A.Baumannii in recent years have the highest detection rate at ICU. Most of them are MDRAB. There are many invasive operations in ICU, such as endotracheal intubation and venipuncture. This leads to long-term A.Baumannii colonization in respiratory tract or venous catheter tips. MDRAB produced due to ICU patients being hospitalized for a long time with extensive use of broad-spectrum antibacterial. MDRAB is spread due to inadequate hand and environmental hygiene and asepsis. Now, we back to the result of my research. The separation rate of A.Baumannii in blood specimens remained at a high level at around 60% during the 2-year study. This means A.Baumannii are significant pathogenic bacteria in the bloodstream infection at the ICU. A.Baumannii in the blood specimens are very resistant to commonly used antibacterials with resistance rate about 80%. The drug resistance of A.Baumannii extends to many types of antibacterials, such as beta-lactam, amyloglycoside, and quinones. Drug resistance rate of less than 50% were only for cephalosporin sulfactam and at 5% and minocycline at 34%. Therefore, very few antibacterials can be chosen to treat ICU patients, and DRAB blood bloodstream infection. A brief word about drug resistance mechanism. The drug resistant mechanism of A.Baumannii include the lack of purine, drug efflux pump, tape side change, producing beta-lactamase and amyloglycoside modifying enzymes, AME for short. Producing carbapenemase is the important mechanism which enables A.Baumannii to resist carbapenemase. In my research, all stages of A.Baumannii in the ICU patients' blood specimens were carbapenemase resistant A.Baumannii, CRAB for short, which with a resistance rate of 100% to imipenem. Control the overuse of carbapenem. The high usage of imipenem has led to CRAB developing quickly and more infection by CRAB in recent years in the ICU. A.Baumannii with a higher carbapenemase always carry the other beta-lactamase and AME, and so multi-drug resistance. Now, CRAB has become an important pathogenic bacteria at ICU. Therefore, we should properly control the overuse of carbapenem to reduce the induction of multiple drug-resistant strains of A.Baumannii. To treat MDRAB bloodstream infection, a combination of cefoperazone, sulbactam, and minocycline is suggested. The resistance rate of MDRAB to cefoperazone sulbactam is the lowest at 5%. My hospital treating reports so that cefoperazone sulbactam has more antimicrobial activity regarding A.Baumannii than all other antibiotics except polymyxin. However, in recent years, polymyxin has been rarely used for treating patients in China because of severe renal toxicity. Cefoperazone is the third generation cephalosporin with strong antibacterial activity but poor stability to beta-lactamase. However, sulbactam has stronger inhibition to beta-lactamase. Drawing cefoperazone with sulbactam significantly increase the antibacterial function by 4 compared to using cefoperazone alone. The resistance rate of minocycline is relatively low at 34%. minocycline is a semi-synthetic tetracycline. It prevents the protein synthesis of the pathogenic microorganism so as to achieve the antimicrobial purpose. The combination of cefoperazone sulbactam with minocycline is preferred for treating the bloodstream infection of MDR-AB at ICU. Antibacterial selection for A.Baumannii must be reasonable based on epidemiological situation of the hospital's drug-resistant bacteria, the result of drug susceptibility, and patient's health condition. Aseptic operations and disinfection isolation. Infections can be caused by medical staff hand and medical devices carrying A.Baumannii when they come into contact with the weak and traumatic patients. Performing aseptic operations and systemic disinfection isolation is very important for reducing the cross-communication of nosocomial infection of A.Baumannii. Conclusions. In summary, my research had four conclusions. First, MDR-AB is one of the important pathogenic bacteria in the bloodstream infection at the ICU. The second, very few antibacterials can be selected to treat MDR-AB. A combination of cefoperazone sulbactam and minocycline is suggested for treating MDR-AB bloodstream infection. Third, hospital should control the overuse of amipenem to reduce the development of MDR-AB. Fourth, ICU should strengthen their environmental hygiene and disinfection of hands and aseptic operations to avoid the nosocomial transmission of MDR-AB. In China, I'm a Western medical doctor as well as a Chinese traditional medical doctor and also qualified hospital infection control. A few years ago, I did research into the effect of combining Chinese herbs named Zhi-Xiang with antibiotic vancomycin in the treatment of MRSA pneumonia. I found that the treatment efficacy of Zhi-Xiang plus vancomycin was superior to vancomycin treatment alone. In my hospital clinic, I found the combination of Western medicine and Chinese traditional medical treatment, including acupuncture, hockey, and the Chinese herbs, have positive effect for many conditions. Now, there is an entirely new world opening up. I think integrate Chinese medicine and Western medicine to treat drug-resistant bacteria have good effect for patients. I hope that more research based on scientific evidence can be done in the near future. It will profit patients and medical work. Thank you for your listening.